Hello, welcome everyone to this 8th edition of the CCD Rounds. My name is Niels Lund. I'm the global lead for Cities Changing Diabetes, and I'm also Vice President for Prevention and Health Promotion here in Novo Nordisk. Cities Change Diabetes, as you know, works to address urban diabetes, particularly with a focus on the most vulnerable populations in cities. The partnership was established 8 years ago and now counts more than 40 cities and a handful of global partners around the world. We use the CCD rounds to share innovations, smart ideas, good interventions that can inspire everyone around the world, and as a way to improve healthy living and reducing risk of disease. And also today, I'm happy to share with you an innovative case that hopefully you can learn from. And actually, for the first time, I'll be joined live here in the studio with a presenter. So I'm delighted to present or introduce to you Peter Costrop. He's the professor of sports and health sciences at the University of Southern Denmark. He will talk about football as medicine, about how a flexible and novel approach to football, or soccer as some of you will call it, how that can overcome health barriers and deliver positive health benefits for vulnerable populations. As we normally do, Peter will speak for 25-30 minutes, and then we'll go into a Q&A session where you'll have the opportunity to participate. You can participate by clicking the question mark on the right side of your screen. Then you type in your question, and then it'll come on a screen down here, and then Peter and I will have a dialogue when we get to that in half an hour's time. So get ready for that. I'll remind you about that opportunity a little bit later. But let's head off into the presentation and hear what the football as medicine is all about. So please go ahead, Peter Costrop. Thank you.
Thank you so much, Niels. Football is indeed the most popular sport in the world, with an estimated 500 million active participants playing regularly, and an expected 3 billion people that will be following the World Cup in Qatar. And today I'll not talk about elite football. I will talk about recreational football, which has a great potential in health promotion. Football as medicine, treatment as fun. And today it's well known that physical activity is a cornerstone in the prevention and non-pharmacological treatment of lifestyle diseases. And so you can say that the Football is Medicine platform stands on strong shoulders, and it adds an extra dimension to the Exercise is Medicine platform. With regards to the Football for Health journey, it has indeed been a long journey. We started out in 2003 with pilot studies, and the first randomized control trial was conducted in 2006. And in 2018, we launched the Football is Medicine platform, which is indeed about science, but it's also about dissemination. It's about developing evidence-based concepts, and it is also about implementation. And for sure, the coaching courses related to the evidence-based concepts are key elements. Throughout this 20-year period, we have been focusing on a multifaceted and multidisciplinary approach, from the lab to the field, and from research all the way to implementation. And for sure, combining sports medicine, sports science, sports sociology, sports psychology, and epidemiology is really important when we are working with health promotion. With regards to the scientific evidence, I would like today to focus on 3 reviews and 3 meta-analyses. With regards to the reviews, the first one was published in 2010, Costrop and colleagues in Scandinavian Journal of Medicine and Science in Sports, clearly showing that football is a combination of 3 training types. It's endurance training, which lowers the fat percentage. It is aerobic high-intensity training called HIIT training, which increases the maximal oxygen uptake. And it is strength training that increases muscle mass and bone mass. Another review was published in 2015 with Jens Bangsbo as the first author in British Journal of Sports Medicine, clearly emphasizing that the heart rates are really high during recreational football training for participants across the lifespan and also for several patient groups. And it's interesting to see that the average heart rate is around 80 to 85% of maximal heart rate, which equals professional football. And also that around 15 to 40% of the total time is in the highest aerobic zone, clearly emphasizing that football training is indeed a combination of endurance training and HIIT training. The last review is from 2018, Costrop and colleagues, European Journal of Applied Physiology, looking into the use of football for female players, for beginners across the lifespan. And it was clear to see that the results showed that football is indeed good strength training with multiple repetitions of specific intense actions such as accelerations, stops, turns, dribbles, and shots, providing a very good stimuli to the strength training. So altogether, football can be described as a combination of three training types, a hybrid all-in-one type of training, combining endurance training, strength training, and HIIT training. And it's interesting to see that recreational football also has some important elements related to fun and a social activity. It's a team sport, and the sports psychologists and sports sociologists have looked into, for example, the very low perceived exertion during football, even though the intensity is really high, and also high levels of flow and low degrees of worry. On top of that, my colleague Leila Ottesen and my wife, Birgitte Costrop, has shown that there's a very high enjoyment of physical activity during a football training, a lot of intrinsic motivation, fun, we stories, and social capital development during football training. And with regards to the three meta-analyses that I was talking about, I will focus here on the three papers from Milanovic and colleagues, one from 2015, another one from 2019, and a third one, which was published only a few months ago. The first one clearly shows that football training is a very effective type of training when we're talking about improving heart function and maximal oxygen uptake. And actually, football training elevates the maximal oxygen uptake by as much as 3.5 milliliters per minute per kilogram in just 3 to 4 months of training, with 2 times 1 hour per week. And the second meta-analysis showed the broad spectrum cardiovascular and metabolic effects of football, with a lowering of fat percentage, a lowering of triglycerides, a lowering of LDL cholesterol, and a marked lowering of blood pressure, actually 11 over 7 millimeters of mercury in just 3 to 6 months of training for 18 to 75-year-olds with mild to moderate hypertension. So that's why we can clearly state that just 3 to 6 months of football training will actually decrease the risk of cardiovascular disease by up to 50%. The last meta-analysis clearly shows positive effects of football training for the skeletal, with marked rapid responses in terms of bone markers, and also marked positive effects on bone mineral density, also in clinically important sites, in 1 year. So altogether, we can now describe that football is a hybrid training form that has marked positive broad-spectrum effects on health in relation to cardiovascular fitness, in relation to metabolic fitness, and in relation to musculoskeletal fitness. And on top of that, it's fun and social. And today we are launching this new Cities Changing Diabetes material, the guide, 5 cases, and also a scientific summary describing the football is medicine holistic model, as you can see in the middle of this slide, where we actually look into the 3 training types, the multifaceted improvements in the physiological health, and why this is important for the use of football in the prevention and treatment of lifestyle diseases in relation to cardiovascular diseases, including hypertension, but also prediabetes and type 2 diabetes and osteoporosis. And on top of that, we have added the elements regarding the fun and social aspects, because it's so important to use health information when we are recruiting subjects, but to ensure long-term adherence, the fun and social aspects may be the most important. So now it's time to talk about the implementation. How can we use this knowledge? How can we use this type of modified football in order to make a change in terms of global health promotion? And I will focus specifically on the use of football against cancer, the use of football against osteoporosis, and the use of football against cardiovascular diseases and type 2 diabetes. And the big question is, how do we modify football so that it fits to these populations? And for sure, this type of football is nothing like what you usually see on the telly. We focus on modified football, so we're talking about training and not games and competition. We're talking about relatively short sessions, 45 minutes, 60 minutes per session, and a maximum of 2 sessions per week in most of our studies. We are focusing on progression, and that relates to each of the sessions, but also the training programs. And we are always starting up with a proper warm-up to minimize the risk of injuries. We use fitness exercise. We use football exercises, usually pair-based drills. And then we play small-sided football games, usually 2 versus 2, 3 versus 3, up to 5 versus 5. And as you can see on the right-hand side, we are adjusting the intensity so that it fits the participant, but also so it's progressively increasing the intensity along the session. So we have one example of a pair-based technical drill with a low intensity, that's called A. Then we have a 2 versus 0. I don't know whether you've ever played 2 versus 0, but it's a good game for patients with which are, for example, elderly, which have balance problems, so that they don't get any pressure from any opponents, and that's a very simple activity and still fun, and with a lot of success because you score a lot of goals. And that's a B intensity game. And then we can also increase the intensity by having opponents. So in the lower right-hand side, we play 3 versus 3, and still modified so that the rules forbid sliding tackles and all those things that you usually see on the telly. And right now, we actually have developed evidence-based programs for all age groups and also for several patient groups, including patients with diabetes, including patients with cardiovascular diseases, and several types of cancer, and also football for socially deprived people. With regards to the program Football for Life, we are preventing osteoporosis, trying to minimize the risk of falls and fractures. We can see from our studies that implementing football and other team sports in schools is actually a really good way to put bone in the bank. We can see that if we ask women to start playing football at the age of 45, or men starting to play football at the age of 70, we see marked increases in bone mineralization also for those adult players. And impressively, if we look at men that have played football their whole life, lifelong footballers, they have stronger bones in their legs than 25-year-old untrained men. And that's really a wake-up call for the 25-year-olds. And at the same time, the 70-year-old footballers that have played lifelong, they have a similar postural balance as young, untrained men. And here you can see some wonderful photos of the so-called Danish soccer grannies team. And actually, we call them the world's oldest football team, and that's because they have 5,000 living years. And how can that be? They are actually 75 players with an average age above 70, so that makes them a really experienced team. When we compare with the Danish national male football team, they only have like 625 living years, so they are quite unexperienced. With regards to football against cancer, we have really good experience with the so-called FC Prostate program and also the Football Fitness ABC after breast cancer. We have seen that football is a really good way to optimize rehabilitation of cancer patients, and for men in anti-androgen treatment, which block their testosterone, we can actually minimize the side effects quite a lot. We can see increases in muscle strength. We can see increases in bone mass and bone mineralization despite the treatment. And actually, in the upper right-hand corner, we can see that the men, after 5 years of intervention, where they are 5 years older, and they have received treatment for 5 years, they still have stronger bones compared to when they started the program. And it's also really interesting for us to see that in a nationwide implementation study, we saw that the number of hospital admissions were 40% lower in the football group compared to the control group. Last but not least, it's very important for me to emphasize and highlight our programs on football against CVD and type 2 diabetes. And in this material now launched by Cities Changing Diabetes, we have described 5 cases using football against pre-diabetes and type 2 diabetes across the world, you can say. The cases are well described. They cover a program in Atlanta in the US, led by Jennifer Frediani and Felipe Lobelo, with recreational football for Hispanic men with prediabetes. We have a program running in Sao Paulo in Brazil, led by Maisa de Souza, with 60-year-old men and women playing football with type 2 diabetes. We've also described the program of walking football for men with type 2 diabetes in Lisbon, in Portugal, led by Romeo Mendes and João Brito. And we've described programs for men and women across the lifespan, and specifically men and women at the age of 55 to 70 with prediabetes on the Faroe Islands. And that's led by Magni Moore and Maj-Britt Skoradal, and also several projects running in Denmark, in Copenhagen, and Odense, and many, many other cities, because it's a nationwide program running for elderly and several types of patients. So implementing for success, that's a really, really important aspect. And it's really to be acknowledged that based on those 5 case studies and case stories, we have had much good advice on how to implement with success. And here I've highlighted some of the statements from Sao Paulo, from Atlanta, from Lisbon, from Tórshavn on the Faroe Islands, and from Odense in Denmark. Educated instructors are really important. It's very important with in relation to adherence that it is fun and social, that there are many possibilities for training. If we want to reach 2 times a week, it would be a good idea to organize 3 or 4 training sessions. It's very important to keep the training simple, and when the players are ready for it, they can move on to small-sided football after this proper 20-minute warm-up. And last but not least, the collaboration between local stakeholders, the football club, and the people that organize and instruct the training is a really important aspect, and we will talk more about that, how to involve those important partners for the implementation. So here is a map of the world describing our program. It's currently running in 22 countries. As you can see, there are many activities in Europe, some activities on other continents, in China, for example, in Brazil, in the US and in Canada. But we certainly have a lot of scope for further expansion of the program. On the right-hand side, we have also described some of the partnerships that are of importance. International partners like the WHO, EU, Cities Changing Diabetes, and all the sporting organizations. For sure, funding is also an issue, but also close collaboration between the municipalities and other local stakeholders. And on top of that, we have been implementing many of our projects through the universities locally, so that they actually try to collect data locally to strengthen the program and to strengthen the storytelling about the program in any given cultural situation. And yes, it has indeed been a great pleasure to participate in the implementation with 300 players in Portugal, and also with coaching courses in Shanghai and Beijing with more than 200 participants. Likewise, on the right-hand side, you see the Danish soccer grannies, also really enjoying being a part of this program. If you want to hear more about this program, if you want to know more about the scientific evidence, if you want to know more about a practical workshop related to the use of football for patients and the use of football for life, then we have annual Football is Medicine conferences. We had the first one in Lisbon in 2018, second one in Odense, Denmark, 2019. Then in 2020 it was on the Faroe Islands, and now for the first time it's a great pleasure to announce that we are now moving on to other continents. We will have the fourth annual Football is Medicine conference in Doha, in Qatar, from the 4th to the 6th of October in collaboration with the WHO. And next year we will go to Atlanta, US, in early April for the fifth conference. And the sixth conference will then return back to Europe in Florence, Italy, in January 2024. In the new Cities Changing Diabetes material, it's also easy to get access to the scientific evidence, the scientific backbone of this program, with links to 6 special issues on football as prevention, football as treatment, football as medicine, and also team sports as prevention. And it's also possible to get a glance of this first textbook about football as medicine, prescribing football for global health promotion, clearly stating that it's time for pupils to play, it's time for people to play, and it's time for patients to play. So let me thank my research group, and especially my close colleagues, Professor Magni Moore from the Faroe Islands, and Associate Professor Morten Randers, and a very special thank to Tina Thea Nielsen, who's done an excellent job in preparing this material along with Cities Changing Diabetes. And indeed, we are looking forward to potential further collaboration after this seminar. And obviously, I would also like to acknowledge the great effort by all the participants in our school sport projects, in our football sport projects for children and adolescents and elderly, and also many of the participants and patient groups that have contributed to our research. And as you can see on the left-hand side, even with 4 representatives of the Danish soccer grannies team, and Åsa Hansen is now a 70-year-old very strong ambassador for this program in Denmark. And she also told me that if you want her to come to your city, she's available to become an ambassador also worldwide. So thank you very much.
Thank you very much, Peter.
You're welcome.
And it's a person, one person applause is not really doesn't do justice to your presentation. But thank you very much. Now we'll go into the Q&A session, and again, there's a question mark on the right side of your screen where you can type in your questions, and then they will pop up magically, so we can bring them into the conversation. I think the approach is was truly fascinating, and this about combining something that is very simple and yet very popular in something that actually. It almost seems that there's nothing. There's it actually does improve many conditions that in the chronic disease space. But I have to say, so now we're back into 8th grade. Back in the 70s when I played soccer or football in my school, and. Together with Christian and Jes, I was not the one to be selected first. Those were Peter and Jørgen and Henrik. So I was selected last, and for me, football wasn't really that enjoyable. And I think it was also a fair assessment by the ones who selected the teams, to pick me and the other two last, because it was the lack of skill, and it probably also was the lack of fitness that played in here. So I'm convinced by the science here. I've found other sports to play, so I think I'm fine. But now I'm getting to the question. You will be meeting people who might have the experience like I did, and maybe they didn't choose an active lifestyle throughout life. How do you overcome some of those worries about lack of fitness, lack of motivation, lack of skill? If you're 55 and you're not a professional player, then how can you then start here in your experience?
After studying 25,000 beginners, I can clearly state that it's fantastic for those that are unfit, because basically they get the biggest improvements. It's fantastic for those that are unskilled, because they get the similar benefits. And we have modified the football, so it's not about winning, really. It's about having fun and becoming healthier. So we have taken away the competition. We've taken away the trophies. We've taken away substitutes. So you can never become a substitute in a football as medicine player, because the basis is we're really happy that people come, and we're really happy that everybody can participate. The training benefits are much greater, but also the elements related to motivation, fun, inclusion, that relates to the principles of pair-based exercises and playing in small groups. Because when playing in small groups, you get a lot of ball contact and you get a lot of success, because you don't have to kick far and long and high balls. You just actually kick and pass the ball to someone that's close to you. And then we usually modify the goals so that everybody can score goals. And as I said, sometimes we play 2 against 0, sometimes 2 against 1, which ensures a proper intensity and a proper complexity, so that it's modified to give success. And it's fantastic to see that those that never believed that they would play football again, if they actually dropped out, and also those that have never played, that when they join in, they think it's fantastic. And I think the principles to introduce a healthy and fun and social and safe type of football is actually to modify the football. So the Danish FA are now talking about 3 types of football. So we have elite football, we have grassroots competitive football, and then we have football is medicine football, which is real recreational football.
Cool. which is actually a good thing, because I think many of those football agencies have been very much been focusing on the elite, but now the opportunity to expand to many more people and get those benefits from that is really great.
Exactly.
In many ways, as I understand, if you stop smoking, there's never a time when it's too late. There's always a benefit from stopping smoking, and you can say, or is there, when you look at is there any time when it's too late to start playing football here? You showed the grannies as an example here, but I could see, at least if I look at people who are in the 60s and 70s, they might have some reservations, bad knees, maybe not the right outfit and stuff like that. Now, and that being an impediment for starting here. What is your experience in terms of, or what can you recommend in terms of?
Usually I say that it's never too early to start. So it's very important to be active, and our school sport programs really show the benefits. And as I said, you really put a lot of bone in the bank by starting as a youngster. But yes, we do see very positive results also for people starting at the age of 70 or 75 or even 80. And basically we are trying to enroll people in the footballer's medicine all the way from the age of 6 to 99. Can it become too late? Yes, for some diseases it can. We have good results for men and women at the age of 70 with osteopenia, but if it moves on into osteoporosis, then it will be very difficult to play football where the impacts are high. So for a group of untrained 50-year-olds, I would definitely recommend that they start right away, so that the osteopenia does not evolve into osteoporosis, because then it gets harder to train in an optimal manner.
Yeah, that makes sense. So you stress very much it both has health benefits, but also has social benefits. What in your view is what is the most important motivation for the ones who are joining, or the ones you're looking to join? Is that I'll get more healthy, my bones will be stronger, or is that the social aspects? What's your learnings from this?
I mean, it's actually a good idea to use the health argument when you are recruiting the participants. So when the Portuguese FA are recruiting type 2 diabetes patients in Lisbon, then it's the health argument that actually makes the people attend the first training. And we have also good experience in actually measuring fitness and measuring rapid changes in body composition after starting the program, because it's good to get this rapid positive feedback on what you're doing. But from our research in sports sociology and also sports psychology, it's clear to see that the most important thing is actually the fun and the social elements, and the third half, where you actually have a good time. So that becomes even more important. And after 12 weeks or half a year or 1 year, when we ask the participants what is the most important part of the football training, they say it's their camaraderie, it's the fun, it's the fun and social aspects, and they are not kind of thinking about the health outcomes anymore. No. It's just been integrated as a part of a healthy and active lifestyle.
One follow-up on that. So you talked about people living with cancer, with cardiovascular disease, diabetes, and so on. If we look at a group living with obesity, where there's maybe also the stigma part associated with it, or the feeling of not feeling comfortable in a setting where you might not be failing because of your body composition and so on. Have you any experience with that group of patients in your work with footballers' medicine?
Yes, we have some experience, and I mean, using walking football or using what we can now call recreational running football, with focus on pair-based drills and small pitches, where it's much easier to get success, even though you are really heavy and relatively slow. If we focus on this type of football, then we've got really good experience also with obese participants.
Yeah. Cool. So there's a couple of questions coming in here. Here's a question from Diogo Abdul, who says, what is the right volume in terms of how do we know whether patients or participants are doing too much or doing too little? I mean, what's the right mix of time and intensity to get the best results?
I mean, we have over the years conducted research related to the dose response aspect, and we see much greater improvements by performing recreational football 2 times per week compared to 1 time per week. In some cases, we can maintain benefits in relation to the cardiovascular fitness, and even get a further increase also in bone mineralization, even when decreasing the frequency of training. But in general, the outcome is better with 2 times 60 minutes per week compared to just 1. And we see some additional effects with 3 times per week, but they are not as big as when you're moving from 1 to 2. And at least there's kind of a plateau of the effects at a relatively high level, a positive level, I would say. But at least in the beginning of an intervention period with patients, it's very important to avoid overtraining. So we for sure recommend that you start up with 2 times 60 minutes per week, and then you can move on to 3 times 60 minutes per week if the participants are really interested in doing so. But we also have really good effects in sticking to twice per week.
Super. And I think to the one who provided the question there, I think there's a lot of more information in the material that is now from today being available online, and also the examples from the 5 different places around the world where this has been
sure.
carried
And I
out.
can see that Diogo Abdul also mentions the intensity aspects, and I think that's quite important. I mean, when we're talking about optimal effects in relation to cardiovascular fitness, it is of importance to have part of the training with high heart rates, and obviously that's built into the program.
Yeah. Another question here online about it's more about the recruitment. Where do you go? And it's from Milos Chismild, who says, first of all, thank you for a great presentation. But where do you find and recruit the players? Is it previous football players, or where do you get the patients? You talked a little bit about collaborations with hospitals and so on, but maybe you can elaborate a little bit about that.
Of course, also. I can. In some of the programs, for example, the program that we call Football for the Heart, it's rather broad inclusion, and we recruit people from many different places, the municipality itself, in the football clubs, with parents and grandparents linked up with the children that are already there. That relates often to for example, people with hypertension, where we have a specific focus on prevention. But when we're talking about patients, for example, the FC Prostate team or the Football Fitness after breast cancer, we have a very close collaboration with the hospitals, with recruitment directly from the hospitals as part of the rehabilitation. And in other projects, including those with pre-diabetes patients and type 2 diabetes patients, we are recruiting subjects from the medical doctors, from the general practitioners, which recommend this program to their patients. And then we design the program so we have open training at the municipality level or in the local football clubs, always with educated coaching instructors, and sometimes with health personnel from the municipality. That could be nurses or physiotherapists or occupational therapists or medical doctors that are trained in this program to conduct, I could say, their service in a local football club. So the partnership aspect is quite important, and we have a lot of experience with different ways to organize it, but a multifaceted approach also in terms of recruitment and maintenance of projects is key. And it's very important to be able to establish a program that is, relatively cheap and accessible and open. And it's also important to try to incorporate the possibility of long-term adherence. Because in some cases we started up with a 6 months program, and then we stopped it, and all the patients, many of the patients, they really, really wanted to continue. So I had to do a lot of work in trying to find a good setting for them to continue. So you have to build that into your plan.
Yeah. There's actually a follow-up from Diogo about a simple question. Do they play with HR bands, so I would assume heart rate bands?
Yes, in most of our studies we have used that. Also as a fast feedback to the players. Usually they think it's really interesting to know, even though they don't run as fast as they do in the national stadium when the national team is playing. We often say, you actually got an equally high heart rate compared to Messi and Ronaldo when they are playing World Cup tournaments. And that's really good fun. And it's interesting to see that even though they don't perceive the exercise that hard, as I showed with the results, it is actually quite intense and thereby also very effective. Yeah.
Interesting. So I once heard a physician say that all of this about health promotion. Well, this is okay. At least it doesn't hurt, right? So continuing a little bit down the line of what Diogo mentioned about measuring and metrics more generally. I think you have shown very well, and you've published and peer reviewed results from this, that it actually does work. It does improve bone density and improves many other factors such as blood pressure and so on. But for for somebody who wants to start this next week or in a month's time, depending on the season, what metrics do you recommend to start with to be able to measure it and see whether you are on the right track or not?
I think you should have a combined approach. So, obviously it's important that you can see that the intensity is correct and proper, that you can actually achieve fast feedback on, for example, the intermittent exercise performance, which relates to the maximal oxygen uptake, where we can see a doubling of the test performance with a patient group within just 6 or 8 weeks. So really positive, rapid feedback. But we also look into physical activity enjoyment scales to know whether we are on the right track in actually establishing this supportive environment where you get success. And we also look into attendance, of course. The higher attendance, the better. And on the Faroe Islands, they are fantastic at this. When they are trying to get an attendance of 3.0 times per week, they get 95% of the participants actually training 3 times per week. So that's impressive. We cannot copy that in any other country in the world. But of course, attendance is important. And then, the feedback from the players. When we are drinking coffee and eating fruit after the training, then it's a very good time to talk about how they perceive the activity, but also how they perceive the development of their disease. And in some cases, we have actually used this forum to make patients talk about their challenges, especially for men, which are not always that good at actually talking about health challenges. In the FC Prostate project, we have found, and the psychologists related to the project have found that this is actually a really good way to make patients talk to each other and talk about their challenges in a different setting than at the hospital.
Safe space, maybe.
In a safe space, in the dressing room or similar.
Yeah. Good. Here's a little bit of a longer question, so I need to read it off the screen from Evelyn. Maybe you know her. We have run a pilot study in 50 to 70-year-old adults. Most subjects were former football players. We trained twice a week with appropriate warm-up and progressive increase of duration in small-sided games, starting with 10-minute games. But we experienced a 25% dropout because of injuries, mainly the calf muscles. Injury risk probably is higher in former players, or is it? ? And how do you cope with those? You have any experience with that?
I mean, we have a lot of experience in conducting the studies to minimize the risk of injuries and trying to combine the healthy aspects, the fun and social aspects, with a safe environment where you try to minimize the number of injuries. Usually we are successful in minimizing the number of severe injuries, but we do have minor injuries where it's not such a big problem to have a time loss, because if you can return after 1 week or 2 weeks, it's still okay. Yeah. But we do have some challenges related especially to those that have played a lot of tournament football before, because they are more aggressive when they play compared to beginners.
So it's more that attitude than their physical composition?
It is a combination, actually, because a previously injured person is more prone to injuries, but it's also because they are so used to play it aggressively that they have some challenges in trying to cope with this new type of football. Yeah. And when we are conducting studies, for example, with futsal, which is 5 against 5, focusing on the match play itself, we do see many more injuries. So try to bring it back to the setting of training, where the 5v5 has to be a minor part of it in the initial phase, where you are actually trying to regain the fitness that you used to have.
So take the competitive element, at least in the beginning.
And especially for those that have played previously, we have seen similar challenges also in our studies.
Yeah. So many years ago, I lived in India, actually for 3 years, and the sport in India is cricket. By any comparison, not so much soccer. There are not that many soccer fields, leads me to the question that soccer is a national sport. You said 3 billion people will be watching the World Championships that are coming up later in the year, and it it's really popular in certain cultures. What, for example, in Denmark, have you any experiences working with groups of other ethnic composition or cultural background that are not as brought up in a soccer culture as I think most Danes are? I mean, even me, even if I wasn't as good as I hoped that I could be.
Yeah, we have recently published some studies on comparing ethnic minority children and adults in our programs. They rated the programs as equally popular, and they had similar positive effects, both in terms of well-being and physical fitness improvements. And actually, those that were not had not previously been enrolled in a leisure time sports club setting, they had the biggest benefits in terms of fitness and well-being, perhaps also because they had a lower starting point. So yes, this type of football does not require the cultural education, and I think that this type of football is basically for everyone. And there are, many of the same elements can be copied into other team sports. Yeah. So we are looking into the use of team handball and basketball and ultimate frisbee and other team sports, where you have a multifaceted activity, where you have collaboration and where you have some fun elements related to the sport. And but for each sport, it's quite important to test it out with various patient groups, because for some of the other sports, the technical level is more important than in football. Yeah. And I mean, it's so good to see that the benefits are not related to the skill level in football. And actually, there's a slogan on the Faroe Islands. It's called "Lose the ball and get fit," because when you lose the ball, you have to you have to stop and turn and run again. And it can be an advantage not to be that skillful.
And I think also the way that you have comprised the program with very low barriers to access or to entry, you can say, into this activity, focusing on minimal amount of rules, high degree of fun. Will, even if you're not culturally, big fan of soccer, then it is a fun game in any case where you do get the exercise and the health benefit.
Exactly.
Yeah. You have demonstrated, and there are some very good cases that online from the 5 different areas where you have run both pilots, but also tried to scale them up. And you mentioned it a little bit that you would like to see this happening in more parts of the world. What's your what would be your main challenges in terms of scaling this to other settings? I mean, of course, resources and money to pay for trainers and so on would be one. But what are some of other factors that you see as critical one, if there are any?
We released the first big study some 15 years ago. And we were on all the headlines on 15 American television companies and saying there's a new slogan for Weight Watchers, burn it like Beckham. And 15 years ago, I thought that this would kind of develop faster. Mm-hmm. And so sometimes I'm asking myself, why do we see this inertia? Or how do we see, why is it not developing faster? I see a lot of trends that we now can move at a faster speed, because several of the football associations are actually bringing this into their strategical thinking, so that we can actually increase the participation for girls and women and for elderly and for patients by prioritizing this type of football. That's quite important. And of course, there's also kind of an inertia in bringing this new evidence into the thinking about how to recommend physical activity. I mean, there is quite a lot of focus on running and swimming and biking, which is great. But this is a new type, and you said innovative type of activity. So there is a delay from when we actually have the knowledge till we get the action. But I don't see that many obstacles in terms of actually expanding this, because it is cheap and accessible, and the prevention benefits are enormous. You know that. Yeah. And I mean, it's relatively easy for us to conduct training courses that would actually ensure a good delivery of the program and a good quality of the program. So I think it's a matter of finding stakeholders that are enthusiastic locally, and that can be many different stakeholders from country to country and city to city. And then you are obviously most welcome to contact us, because we've got a lot of experience, and we can definitely help out in conducting such courses and actually give some good advice on how to implement it.
And you have experience from many parts of the world in doing that.
For sure. Yeah.
So Actually, a follow-on to the question I had just before, where we looked at where I spoke about ethnic minorities. There's a question from Anne here. In terms of diabetes prevention, football for persons with overweight or pre-diabetes, do you have any data on the socioeconomic status of your participant, and how do you seek to recruit high-risk populations with various backgrounds? So not necessarily the ethnic part, but if people have a lower socioeconomic status, do you track that, or have you done anything focused for some groups, for example, in particularly public housing neighborhoods or something like that?
I mean, we are in some of the studies, we are actually looking into this and try to incorporate that. And so far, we haven't seen any differences in the outcome effects related to socioeconomic status. It seems as if football in itself is a sport with a quite broad recruitment from many different socioeconomic backgrounds. I mean, you know, golf and boxing, they're very different in terms of socioeconomic background in the recruitment. But football has a quite flat recruitment, which is a big advantage. And in some of the projects, we have looked specifically into recruiting people that are socially deprived or homeless. Mm-hmm. And it's actually a really strong tool for them as well. And that gives me hope that we can actually use this also as a way of improving the possibilities for those that have a low socioeconomic background.
Nice. I think we will get to the last question now from Stephen O'Connell. Excellent presentation and discussion. My question is to note, how do we recognize the leaders? Many of them who would be volunteers, at least in many settings, including the Danish one, that enable the delivery of football as medicines programs.
I mean, I think we have to look out for new types of coaches. I mean, when I run along with my colleagues in Denmark football fitness courses or football for the heart courses, I see a lot of new coaches coming in. Firstly, we see a lot of women, which is not that usual in football coaching courses in Denmark. We see a lot of women. We see a lot of physiotherapists, occupational therapists, nurses, sometimes also medical doctors that can see that they can use this as a tool to be really effective, and also to have the fun and social elements to their own delivery of treatment. Mm-hmm. And in a way, it's really funny also to
so
see
the intrinsic motivational aspect.
Also for the health personnel delivering the programs, and we can see that in our programs the instructors are really popular, and that also relates to pedagogues and teachers in schools. They become very popular when they are involved in such a program, delivering treatment and delivering learning in a positive manner and a positive setting. So I hope that we can actually recruit many more coaches, and also some of those that are not already in the football clubs.
Cool. We are getting very close to the end. Actually, we are at the end. So thank you very much,
thank
Peter.
You.
And
it's been a pleasure.
And thank you for joining me here in the studio. It was great to have this, lively debate here. So to you online, we hope that you enjoyed this. If you missed a point or two, or want to zoom in on some of the specifics of the presentation, it will be available on our YouTube channel soon after this. Soon after we have completed here. If you have some specific questions that you did not get into the chat here, then you can send an email to info@citieschangingdiabetes.com, and then we will connect you with Peter and his team here to present that. And most important, as I think we've said many times now, there is there's a handbook, a guide with 5 cases about how this has been applied, what you need to do to get started on this. That is now available at citieschangingdiabetes.com, and that we are happy to share with you. You go into Get Inspired, and then you look for best practice cases, and you can find them under physical activity. So the only thing I have to say now is to thank you for tuning in. We will be back in October on the 26th, where we will be talking about innovative financing models for diabetes prevention programs. Something a little bit different, but still associated with diabetes prevention. So thank you again, Peter. Thank you for coming, and have a wonderful day.